Thank you. My name is Roland Valori. I'm the head moderator for the session Common Difficulties in Gastroscopy. We're moving up the gastrointestinal tract to the stomach today and the esophagus, and we've got some excellent speakers and moderators. I'd like to introduce our colleague, Dr. Ercan Çezmeli, Professor Ralph Bishops from Louvain, and Suzanne Ribeiro from here in Ghent. So just tell us what you're doing and what you're aiming to achieve with this patient.
So let us first introduce the case to you.
Indeed. So I'm going to present the case. It's a 76-year-old male who had a gastroscopy in August because of dysphagia, showing reflux esophagitis grade D, a large Barrett esophagus C10 M10, and then also a small hernia of the stomach of 3 centimeters. There was also a gastric ulcer in the antrum of 3 millimeters, Forest 2C classification, and below you can see some images.
Yep.
Okay, thank you. So with me I have Dr. Dominique Duwolf, who is a colleague of mine, and together we would like to walk through this case. So he was on high-dose PPI to let the esophagitis heal, and now we're actually here to inspect the Barrett's. Just quickly, the ulcer that was in the antrum shows, and now there's only scarring left. So that was surely that was a benign ulcer, but that's of note. We are going to show you the Barrett's. So of course it's everyday endoscopy, and we would actually like to talk about how to assess a Barrett, some basic principles, and we want to start with measurements. So we have the top of the Z line right here, which is at 28 centimeters for us, and then we look if there's any tongues of Barrett's going out. There's not much of tongue, not real significant ones. It's a bit an irregular Z line rather than really Barrett tongues. You agree? Yeah. Maybe this one you could.
Yeah. Extra tongue.
Exactly. And then the next, I think this might be challenging for mainly trainees who started off. Where does the Barrett start? Because obviously you have no Z line. You need to know where you start your biopsies and your careful inspection, and we tend to look at the gastric folds for that. You can actually desufflate the lumen a little bit just to see where they exactly end, and that's where your measurement should be. For us, this is at 37, and then we look at the diaphragm impressions, which are here at 40.
I think the live case was a really nice introduction to my talk. So if you can see the slides, we can go ahead. Thank you. See, there's my disclosure. So the objectives of this talk is to learn how to optimize your daily endoscopy to improve diagnosis, neoplasia detection, and characterization. And you could already see this in the live demonstration. Also, I want to address the reporting of Barrett's and then understand when treatment or referral for treatment is indicated, and understand the importance of follow-up of Barrett's before and after treatment. So the first thing that is really important to pin out is that the Barrett's should not be overdiagnosed. And the definition is clear. You need at least 1 centimeter of Barrett's or columnar lined esophagus and the presence of intestinal metaplasia. And Lobko already alluded to that, and we spent quite a bit of time every year trying to get rid of the follow-up of these patients. Thank you for your attention.
Raf, that's a brilliant overview and certainly has increased my knowledge exponentially on this. I mean, I used to be very interested in Barrett's from the health economic point of view, and I was very much a cynic until all the mucosal therapies came along. But just looking at this now, it seems that this is an immensely complicated algorithm, for one thing. 2, requires special techniques, special competencies. Do you think there's any justification for the everyday endoscopist doing Barrett's surveillance, or do you think the Barrett's surveillance should be in small specialised centres, done on special lists, you know, et cetera, et cetera? What's your view about that? Because the view may impact on people's income as well as their job satisfaction, et cetera. I would imagine that surveillance of Barrett's is a big income earner for some people in some jurisdictions.
No, I think it should be in general care because it's so prevalent,
Okay.
especially in Western European countries, that if we had to centralize just the surveillance, first of all, it becomes a little bit of a tedious job to do this every day,
Sure.
every morning,
Sure.
full list of that. And second, I think it's so widespread that we cannot ask people to come to like several centers. For the long segments, maybe yes,
Yes.
but for most of it, I think we just need to do, like the title says, everyday
Yes.
endoscopy
So
better,
this-
and that will work.